Rheumatic complications of diabetes mellitus, DM, are common and involve both the joints and connective tissues. These manifestations can be related to the chronic metabolic effects of hyperglycemia on collagen, microvascular complications, and inflammation. Key rheumatic complications include 1. Diabetic keroarthropathy, limited joint mobility, LJM, characterized by thickening and stiffness of the skin over the hands. Patients may have difficulty flexing or extending fingers fully, often associated with long-standing diabetes. 2. Frozen shoulder, adhesive capsulitis, marked by stiffness and pain in the shoulder joint, more common in individuals with diabetes and can lead to significant loss of movement. 3. Trigger finger, stenosing tenosynovitis, a condition where the finger gets stuck in a bent position due to the thickening of the tendon sheath, more frequently seen in diabetic patients due to glycation of tendon collagen. 4. Carpal tunnel syndrome, CTS, caused by compression of the median nerve as it passes through the wrist. Diabetic patients are at higher risk due to nerve damage and microvascular changes. 5. Diffuse idiopathic skeletal hyperostosis, ISH, a condition where ligaments and tendons harden and become ossified. Diabetics are predisposed to developing spinal stiffness and ossification, particularly in the thoracic spine. 6. Charcot joint, neuropathic arthropathy, a progressive destruction of weight-bearing joints, commonly seen in the feet and ankles, results from neuropathy and loss of protective sensation, which leads to joint damage and deformity. 7. Gout and pseudogout. Diabetes increases the risk of hyperuricemia and gout due to impaired kidney function and insulin resistance. Deposition of calcium pyrophosphate crystals, pseudogout, is also more frequent in diabetic patients. 8. Osteoarthritis. There is an increased prevalence of osteoarthritis in diabetic patients, particularly in weight-bearing joints, likely due to the metabolic disturbances associated with insulin resistance. Managing these complications involves both controlling blood sugar levels and addressing the specific musculoskeletal issues to prevent disability and improve quality of life. Yes, diabetes can significantly affect pre-existing rheumatic autoimmune diseases in various ways, leading to both direct and indirect complications. 1. Increased risk of infections. Patients with autoimmune diseases such as rheumatoid arthritis, RA, or lupus who develop diabetes may be at an even higher risk of infections. Diabetes impairs the immune system, making it more difficult to fight infections, which is further exacerbated by immunosuppressive treatments commonly used in autoimmune diseases. 2. Worsened inflammation. Chronic hyperglycemia in diabetes leads to an increase in pro-inflammatory cytokines, which can exacerbate the inflammation in conditions like RA, systemic lupus erythematosus, SLE, or psoriatic arthritis. This could worsen joint pain, swelling, and tissue damage. 3. Impact on medication effectiveness. Some medications used to treat autoimmune diseases, such as corticosteroids, can raise blood glucose levels, making diabetes harder to control. On the other hand, poorly controlled diabetes may alter the metabolism of other disease-modifying anti-rheumatic drugs, DMARDs, or biologics, affecting their efficacy. 4. Complications of steroid use. Corticosteroids, which are frequently used in the management of autoimmune diseases, can worsen diabetes by increasing insulin resistance and promoting hyperglycemia. This creates a vicious cycle where controlling inflammation worsens diabetes control, and poorly controlled diabetes further increases inflammation. 5. Cardiovascular risk. Both diabetes and autoimmune diseases like RA or lupus are associated with an increased risk of cardiovascular disease, CVD. The presence of both conditions amplifies this risk, as inflammation and hyperglycemia contribute to atherosclerosis, leading to higher rates of heart attack and stroke. 6. Increased risk of bone and joint complications. Patients with both diabetes and autoimmune diseases have an increased risk of musculoskeletal complications like osteoporosis due to chronic inflammation, glucocorticoid use, and diabetic bone disease and tendon issues due to advanced glycation end products affecting tendons and ligaments. 7. Poor wound healing and increased risk of neuropathy. In autoimmune conditions like lupus, patients may already have skin lesions or ulcers, and diabetes can worsen these by impairing wound healing. Similarly, diabetic neuropathy can combine with autoimmune joint involvement to increase the risk of joint deformities, especially in the feet, e.g., Charcot joint. Managing both conditions together requires careful balancing of treatment strategies to control autoimmune disease activity while avoiding worsening of diabetes or its complications. Close monitoring and individualized treatment plans are essential in such cases. Rheumatic diseases can have a notable impact on glucose metabolism and may contribute to the development or worsening of diabetes. Several factors link rheumatic diseases to alterations in glucose metabolism, and these connections are often bidirectional, meaning that the inflammation and treatment of rheumatic diseases can affect glucose levels, while diabetes itself can influence the course of rheumatic diseases. The key impacts include: 1. Chronic inflammation and insulin resistance. Many rheumatic diseases, such as rheumatoid arthritis, RA, systemic lupus erythematosus, SLE, and psoriatic arthritis, are associated with chronic systemic inflammation. Inflammatory cytokines like tumor necrosis factor alpha, TNFA, interleukin 6, IL 6, and C reactive protein, CRP, are known to promote insulin resistance, making it more difficult for the body to regulate blood sugar. This chronic inflammation interferes with insulin signaling, reducing the body's ability to use glucose efficiently, which can lead to hyperglycemia and, eventually, type 2 diabetes. 2. Glucocorticoid therapy. Corticosteroids are commonly prescribed to manage the inflammation in rheumatic diseases. However, they are known to induce hyperglycemia by promoting gluconeogenesis in the liver, increasing insulin resistance, and impairing insulin secretion from the pancreas. Long-term use of corticosteroids can lead to steroid-induced diabetes, especially in predisposed individuals or those with pre-existing insulin resistance. 3. Obesity and sedentary lifestyle. Rheumatic diseases, particularly those that affect mobility like osteoarthritis, RA, and ankylosing spondylitis, can limit physical activity due to joint pain, stiffness, or fatigue. Reduced physical activity is a major risk factor for obesity and metabolic syndrome, both of which are strongly associated with the development of type 2 diabetes. Patients with rheumatic diseases may have a higher risk of gaining weight, which further contributes to insulin resistance and dysregulated glucose metabolism. Number 4. Altered lipid metabolism. In addition to impacting glucose metabolism, many rheumatic diseases are associated with dyslipidemia, abnormal lipid levels, characterized by elevated triglycerides and low HDL cholesterol. This lipid disturbance can further contribute to insulin resistance, increasing the likelihood of developing diabetes. Inflammation-driven alterations in lipid metabolism also increase the risk of cardiovascular disease, a concern for both diabetic and rheumatic patients. 5. Impact of inflammatory mediators. Pro-inflammatory cytokines like TNFA not only promote insulin resistance, but also impair pancreatic beta cell function, reducing insulin production. The combination of reduced insulin sensitivity and impaired insulin secretion can lead to the development of type 2 diabetes. In diseases like RA, studies have shown that higher inflammatory markers, e.g., CRP levels, correlate with worse glucose tolerance and higher insulin resistance. Anti-rheumatic drugs and glucose metabolism. While corticosteroids worsen glucose metabolism, other treatments for rheumatic diseases, such as TNFA inhibitors, have been shown to improve insulin sensitivity and glycemic control in some patients with RA or psoriasis. By reducing systemic inflammation, these biologic therapies may have a protective effect on glucose metabolism. However, other DMARDs, disease-modifying anti-rheumatic drugs, such as methotrexate or hydroxychloroquine, have mixed effects on glucose metabolism. Hydroxychloroquine, for example, has been associated with improved insulin sensitivity in some studies, while others may have neutral effects. 7. Increased risk of cardiovascular and metabolic syndrome. Rheumatic diseases, particularly RA and SLE, are associated with an increased risk of metabolic syndrome, which includes insulin resistance, central obesity, hypertension, and dyslipidemia. Metabolic syndrome is a major risk factor for the development of type 2 diabetes. Patients with systemic inflammatory diseases are also at a higher risk of developing atherosclerosis and cardiovascular disease, both of which are more prevalent in people with type 2 diabetes. Number 8. Stress and glucose metabolism. Living with a chronic rheumatic disease can lead to physical and emotional stress, both of which can elevate cortisol levels, contributing to insulin resistance and poor glucose control. This is especially relevant in autoimmune conditions where flare ups are associated with increased stress. Summary: the interaction between rheumatic diseases and glucose metabolism is complex. Chronic inflammation, common in many rheumatic diseases, promotes insulin resistance and disrupts glucose homeostasis. In addition, the treatments, e.g., glucocorticoids, used to control rheumatic diseases often exacerbate hyperglycemia. Proper management of rheumatic diseases, including minimizing glucocorticoid use, controlling inflammation, and encouraging physical activity, is essential to reducing the risk of diabetes or worsening glucose control in affected patients. The management of diabetic patients with rheumatic diseases requires a multidisciplinary approach that balances the control of both conditions while minimizing the risk of complications. Updated guidelines for the management of these patients focus on optimizing glucose control, reducing inflammation, and addressing the musculoskeletal and metabolic aspects of both diseases. Key recommendations include the following: 1. Comprehensive patient assessment. Individualized treatment plan. Consider the type of rheumatic disease, the severity of diabetes, and the impact of the medications used for both conditions. Monitoring of glucose levels. Regular blood glucose monitoring is essential, especially in patients using medications that can affect glucose metabolism, e.g., corticosteroids. Assessment of cardiovascular risk. Given the heightened cardiovascular risk in patients with both diabetes and rheumatic diseases, assess cardiovascular risk factors regularly, including lipid profiles, blood pressure, and kidney function. Number 2, medication management. Minimizing glucocorticoid use. Avoid or minimize long-term glucocorticoid therapy due to its potential to worsen insulin resistance and promote hyperglycemia. Use the lowest possible dose for the shortest duration when corticosteroids are required, and consider alternative treatments where possible. For patients on corticosteroids, intensify blood sugar monitoring and adjust diabetes medications accordingly to maintain glucose control. Use of DMARDs and biologics. Methotrexate and hydroxychloroquine are preferred for patients with rheumatic diseases and diabetes, as they are associated with a neutral or even favorable effect on glucose metabolism. TNF-A inhibitors, e.g. adalimumab, infliximab, and IL-6 inhibitors, e.g. tocilizumab, can improve inflammation and have shown potential benefits in improving insulin sensitivity. These are suitable options for patients with diabetes and rheumatic diseases like RA or psoriatic arthritis. Consider JAK inhibitors, e.g. tofacitinib, with caution, as they may increase the risk of cardiovascular complications, which is already elevated in diabetic patients. Monitor the impact of any new biologic or DMARD on glucose metabolism and adjust diabetes treatment if necessary. 3. Multidisciplinary coordination. Endocrinologist and rheumatologist collaboration. Coordinate care between the endocrinologist and rheumatologist to optimize both diabetes control and rheumatic disease management. Patient education. Educate patients about the impact of their medications on blood sugar levels, the importance of medication adherence, and lifestyle changes. 4. Lifestyle interventions. Diet and exercise. Encourage a diabetes-friendly diet, e.g. low in refined carbohydrates, high in fiber, and moderate in healthy fats that supports both glucose control and reduces inflammation. Physical activity. Tailor exercise recommendations to the patient's ability, especially if joint pain or stiffness limits mobility. Low-impact exercises like swimming, walking, and cycling are recommended to improve insulin sensitivity and maintain joint function. Address obesity as a shared risk factor for both diabetes and rheumatic diseases, focusing on weight reduction strategies where appropriate. Smoking cessation and alcohol moderation. Advise on smoking cessation and reducing alcohol intake, both of which contribute to poor glucose control and worsen inflammation. 5. Monitoring and managing complications. Musculoskeletal complications. Diabetic patients are at higher risk for musculoskeletal conditions such as diabetic chiroarthropathy, frozen shoulder, and carpal tunnel syndrome. These complications may overlap with symptoms of the underlying rheumatic disease. Regularly assess for diabetic foot issues, particularly in patients with neuropathy, and manage Charcot-arthropathy aggressively to prevent deformities. Neuropathy and nephropathy. Monitor for diabetic neuropathy and nephropathy, which can compound the effects of rheumatic disease. Nephropathy can affect drug metabolism and increase the risk of side effects from DMARDs. Cardiovascular disease. Given the combined risk of diabetes, inflammation, and the use of certain anti-rheumatic medications, patients should be monitored closely for signs of cardiovascular disease. Aggressive management of hypertension and hyperlipidemia is critical. Consider statins and antihypertensive agents that are known to reduce cardiovascular risk without worsening glucose metabolism, e.g., ACE inhibitors, ARBs, and calcium channel blockers. Number 6, special considerations for steroid use. Steroid tapering and withdrawal. Gradually taper corticosteroids when disease activity allows to reduce the risk of steroid-induced diabetes or worsening glucose control. Steroid-sparing therapies. Use steroid-sparing agents such as methotrexate, hydroxychloroquine, or biologics early in the treatment plan to minimize reliance on glucocorticoids. Prophylactic measures. For patients on long-term steroids, consider prophylaxis against osteoporosis with calcium, vitamin D, and bisphosphonates, as well as close glucose monitoring to detect early signs of hyperglycemia. 7. Screening and prevention. Early screening for diabetes. Rheumatic patients on long-term glucocorticoids or with high levels of systemic inflammation should be screened early and regularly for prediabetes and type 2 diabetes using fasting glucose, HbA1c, or an oral glucose tolerance test. Prevention of diabetes. Patients with rheumatic diseases who are at risk of diabetes, e.g., those with obesity, metabolic syndrome, or a family history of diabetes, should be counseled on lifestyle changes and weight loss strategies to prevent the development of type 2 diabetes. 8. New and emerging treatments. GLP-1 receptor agonists and SGLT2 inhibitors. These newer classes of diabetes medications have shown cardiovascular and renal protective effects and may be beneficial for patients with both diabetes and rheumatic diseases. They also help with weight loss, which can benefit joint health. Metformin. Metformin, a first-line treatment for type 2 diabetes, may also have anti-inflammatory properties and can be safely used in patients with most rheumatic diseases. It is a preferred option for managing hyperglycemia in these patients. Summary. The management of diabetic patients with rheumatic diseases requires a careful balance between controlling inflammation and maintaining glycemic control. Individualized treatment plans that minimize steroid use, prioritize lifestyle changes, and involve close coordination between specialists can help mitigate the risks associated with both conditions. Screening for cardiovascular risk factors, monitoring for diabetes-related complications, and using medications that improve both glucose control and inflammation are key components of modern management.